what we're focusing on this year, in 2017, is our care redesign amendment. So we're still under, we're in the end of the, the beginning of the 4th year of a 5-year all-payer model demonstration. So our progression plan will pick up in 2019. So in 2017 and 2018, we're still operating under our current model. So we have a couple of care redesign amendments that were approved by CMS that we'll be bringing to the legislature actually to make sure that we can get those implemented. And those are a healthcare improvement plan and a chronic illness, a chronic disease and complex disease improvement plan. And those are really to incentivize and coordinate care between hospitals and providers. The Hospital Care Improvement Program is one that connects the hospitals with hospital-based physicians, and the Chronic Care one is one that connects hospitals with other community providers. And this is really important to share data, to align incentives, to try to make sure that all the providers are working in the right direction. And those care redesign amendments will be MACRA eligible. So we want to focus on getting those up and running for our physician community and for improved healthcare delivery. So that's our 2017 2017 focuses. In 2018, we will hopefully be implementing the primary care model that Dr. Haft is going to be talking about that will really transform the coordination of primary care for patients. And again, still we'll be working towards our second phase goals of total cost of care and system-wide responsibility. So the first 2 years we're still kind of under the current model, and in 2019 we'll begin, January 1st, 2019 we'll begin the second phase, which is going to include more system-wide responsibility, total cost of care. We're focusing a lot on Medicare and dual eligible groups and implementing those payment and delivery system reforms to help reach our goals. Just a couple of quick slides on rural health nationally. This is data from CDC and from a paper on iVantage Health Analytics. And this is probably nothing new to anybody in this room, but there are significant challenges for maintaining good population health, maintaining good health metrics in rural settings. From the CDC, they cite increasing morbidity rates in rural communities as opposed to urban communities, especially in the female population, which is really concerning. So over the same time, the CDC reports that rural adult women have experienced an increase in heroin and opioid overdoses, suicides, and other alcohol and addiction-related diseases. For hospitals specifically in rural hospitals, they are facing extreme pressure. Nationally, rural hospitals have faced declining margins of 5% annually since 2011 due to shrinking inpatient demand. So those margins have been going down as there is less demand for inpatient services. Nationally, 68 rural hospitals have closed over the last 5 years, and an additional 670 are vulnerable for closure based on that those declining margins. And as you know, the rural hospitals are extremely important in the healthcare delivery system for the community. Good news, bad news. The good news is that other states have been looking to Maryland, actually, to help address those deficiencies in healthcare delivery in rural communities. Maryland has been a model for connecting providers, for managing populations, for coordinating care. And 2 states just this year have gone to CMS for approval to do rural health models similar to Maryland's rural health model. So in Pennsylvania, they're in CMS clearance. Actually, we talked with the woman who's leading the Pennsylvania model, and they were at the White House yesterday, on Friday, hoping to get this done. So this might have already been approved, but as of Friday, it was still in CMS clearance. But it begins with 6 rural hospitals on global budgets, and it will expand to 30 out of the 42 rural hospitals by year 3. And it's really similar to what we've been doing here in Maryland. They've been transitioning from an inpatient-focused delivery to greater emphasis on outpatient services and population health. So kind of moving towards where we're going, not looking at only hospital, acute level services, but services across the spectrum. Because as we all know, hopefully we don't spend too much time in hospitals. Most of our care should be in other care settings. So transitioning that focus. Focusing on improved quality and safety, really important things. And leveraging technology, telehealth, other technology that can connect rural communities. For Pennsylvania specifically, to help their hospitals reach financial sustainability and meet community health needs, they've really been pushing providers to shift their focus from acute care services to outpatient services, similar to Maryland. And then finally in Vermont, they just were approved for an all-payer ACO model, similar to Maryland's, that drives system-wide changes in controlling costs and improving health care and outcomes. It again encourages collaboration with community providers, making those connections with the community's providers, and they have a specific focus on mental health, behavioral health services. So in Vermont, they are specifically looking at opioid and other addiction issues and improving access to services for those issues.
So I think that's really important to me, because this is really about the why for me. Why are we here doing this? I'm going to give you a little technical stuff now to talk about the comprehensive primary care model. Katie was wonderful in introducing it. I think she's done a great job hitting the ground running and understanding the complexities in healthcare and how to deliver healthcare across the state. But this is really, for me, and I think for all of us, it's really has to start with the why are we doing this. And the why really is to create a healthier Maryland. It's to have affordable, accessible, high-quality healthcare for everyone in the state. Because when you achieve that goal, having met all of those elements, then we've really done something that's important and sustainable. To my mind, being a rural health provider, having my deep roots there, it's really going to be necessary to transform what we do in primary care. So how many primary care doctors are in the room here today? We do have a representative. So, I mean, this is representative of the fact that there are very few primary care doctors, insufficient numbers in the state, and certainly a disproportionately insufficient number in rural communities. I know how difficult it was for me as a rural health provider to try to recruit more rural health primary care doctors. And when they were there in these settings, they were found that they were taken upon to deliver more and more care to more people in a smaller interval. They were on a hamster wheel because of the great demand. And it was unsatisfying. So I think we've come to the understanding that not only do we need to increase the numbers of providers in rural health in rural communities, but we also fundamentally need to transform the way they deliver care to make it more efficient and effective. And that's an important why. And one of those transformations is moving from volume, the sense that you always have to see more and more people. When I started out seeing patients, really in my career, if I saw 15 patients in a day, and that was a great day. It was wonderful. It was enough. My wife was happy. We could feed all six of our kids, and the income was fine. Now the doctors that are coming out with a great burden of debt, and with the way reimbursements are, have to see 30 or 35 or even 40 people a day. Unbelievable to me that you can see that many people and deliver good care. So we fundamentally need to transform from seeing how many people we can see to delivering the best care for every person that we see. And we've come to a place in healthcare right now in the United States, where some of the moving forces are somewhat aligned, and they particularly are aligned now in Maryland with what's happening with the hospitals in their waiver, and they're moving, I'll talk about it in a minute, their waiver to move from volume to value, and what's happening on a national focus with the movement with CMS, making all payments under MAPRA value-based payments. And Maryland is ideally positioned to make a significant change in this way, and actually to be a leader. I think we already are a leader, but to be a leader in how we pay for and how we deliver health care, and really show the whole country that there is a path forward, and we can actually deliver affordable, accessible, high-quality health care to everyone in this country. Our new model leverages something that CMS and the Center for Medicaid and Medicare Innovation has put out across the country, the CPC Plus, the Comprehensive Primary Care Plus model. We didn't get an award to do one of those models in our state for one reason or another, but CMS came back and said, you know, Maryland is such a unique state, we're going to give you sort of the ability to make your own comprehensive primary care model and make it available on a voluntary basis to every provider in the state who wants to join it. And you know what? They also said they're willing to double down and make major investments in the state to make this transformation happen across the state, and particularly in rural areas. So this is kind of the general schematic. Let's see if there's a pointer on this. Yep, there is. So this is CMMI, the Center for Medicare and Medicaid Innovation, who said we'll make some investments, big investments, $100 million or more in investments in primary care. We'll put them through a coordinating entity that the state will establish, will help run the programs essentially. And then we'll do something that's really unique in Maryland. It's different from any of the other states in the country, is we'll set up what are called care transformation organizations around the state. And these care transformation organizations, to a great extent, will already be existing structures, things like local health improvement coalitions, or local health departments, or ACOs, or integrated delivery networks, things that are already existing in the state, but would be empowered and funded to work particularly with patient-centered homes. This is where the action is, to support all of these people in the middle here. These patient-centered homes are where the primary care doctors and those people those providers that your patients and you consider your primary care doctor, not just because they've been designated as a family practice doctor or an internal medicine doctor, but if you as a senior citizen, if you have primarily a heart problem and you only ever see your cardiologist, that would be your patient-centered home. So it's not limited in scope, it's broad in scope to really follow the interests of the patients. And that's where the activity would occur. It would be here where real transformation would occur, that the practices of those doctors would have more time to see patients. So here's patient-centered homes. They deliver patient-centered care. This is about the joy, going back to the roots and saying, when you have a patient in front of you, the doctor shouldn't rush through and say, take this, take that, take this. There should be a decision, a discussion between the patient and their provider to talk about what the patient really wants. And that's really gone away because of time constraints to a great extent from what we do in care now. We focus more on the computers and less on the patients. So this is all about making joint decision-making abundant input from the patients important in the healthcare that gets delivered. Inasmuch as every one of these patient-centered homes will be required to have patients advising them on how they would like to have their care delivered.